Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Dr. Seger, Dr. Desai, thank you so much for joining me. We've been getting a lot of questions about pregnancy and COVID-19. People are wondering about getting pregnant during this time. They're wondering about issues and risks around if they are pregnant. Dr. Seger is a close friend of mine. She's also the medical director for the OBGYN service at her hospital there in Ashland, Oregon. She also has a master's in public health from the University of Washington in epidemiology and maternal child health. So I really felt like you were the perfect person to ask these questions to, Dr. Seger. So I really appreciate your time. Dr. Desai is also a close friend. She happens to be an ER doctor in New York City in a very busy emergency department. And we had this podcast planned, and I got a really kind of disturbing to me email this morning from Dr. Desai. Poonam, do you want to just kind of tell your story, what's going on there in New York? The email I got from you this morning, it really kind of put me on my heels a little bit. I know you're 26 weeks pregnant, and in the email you mentioned that you had actually tested positive last night, which scared me, and so I can't imagine how you're feeling. So just tell me how things are going there in New York City where you're on the front lines.
Yeah, so I'm an ER doctor in New York City, and I work at two of the largest hospital systems here. So I've been working back and forth between two ERs, helping them cover their shifts during this pandemic. And I've also been covering a lot of telemedicine calls for them. The ERs have been so crowded that we're not able to see all the patients we want to see. So on my days off, I've been covering telehealth, urgent care telehealth visits. In the last few weeks, we've seen an enormous increase in patients that are coming in with many of the symptoms of COVID, from diarrhea, fever, chills, shortness of breath. Our ERs here have been packed to the brim of patients that are severely short of breath, many of them requiring vent management, ICUs. Our healthcare workers are also very bombarded with all these patients, and not to mention all the exposure. And while I was seeing all these patients and working these shifts, it was definitely in the back of my family's, mind and my husband's mind that, hey, are you increasing your exposure? Is there a possibility you can also get COVID? During these shifts, when we first started, we didn't really know much about COVID. So a few weeks ago, a month ago, we weren't all wearing masks when we were working. It wasn't until recently that we were told that you should be wearing a surgical mask or an N95. And at some places, we switched to a surgical mask. At others, now we just wear N95s and goggles. So a few days ago, I started having symptoms where I woke up and I had some sputum, which never really happens, and it was blood tinged a couple of times that morning, which scared me. And I had also noticed that I had sore throat and a severe headache. And all three of those are symptoms I've never really had unless I feel like I'm getting the flu. And during COVID, I got a little more worried than normal. I called my boss and he said, come right in and we'll get you tested, especially because you're working so many shifts coming up in, the upcoming week. So I got tested. Luckily, we were able to get the results pretty quickly. And last night I found out that my test did come back positive.
So I know you're a great physician. I know you've been taking all the precautions that you need to, and this has affected you. This is one of the big things that I've been really worried about is this spreads. If our healthcare workers on the front lines are affected, that's a bad situation for all of us. So you look like you're doing great. How are you feeling right now?
I feel good right now. I look back to all the shifts that I've worked and I keep thinking, was there something I could have done? Did I miss a time where, I wasn't wearing my N95, or maybe that sip of water I took, I shouldn't have taken it. And, you go through all the scenarios in the back of your mind. And while you're working an ER shift, every time you remove that mask, there's always something in me that's like, should I be doing this right now? Is this water really necessary? Is this break really necessary? Because I know that I'm exposing myself and my baby while I'm working. And it's a thought that I think every single physician, healthcare worker that's working right now has when they are taking care of these patients, that what if I get this? What if I take this home?
Well, I want to talk to you a lot more about your experience, but I know you're going to be joining us for the virtual summit and you'll be able to tell us more and then answer some questions. But today we want to specifically talk to all the people who are in your situation. You're pregnant, you've been exposed, and I want to go through just a few questions that we've been sent. Okay, so it turned out the next 40 minutes of discussion became obsolete within a couple days before we could release this. So we recorded again with Dr. Seger, but I was unavailable this time. Poonam was unavailable, and Dr. Jeff Chamberlain, who was also on the podcast later, was unavailable as well. So Mike is going to talk to Hillary now and ask all the questions to get more up-to-date answers, at least as of today, March 28th.
All right, so today is March 28th. I'm here with Hillary Seger, who is a good friend, an OBGYN down in Ashland, Oregon. She's also got a master's of public health, so obviously she's the perfect person to be talking with us today about coronavirus and how it can potentially affect pregnancy. I will start off by saying that we actually recorded this 3 days ago with Matt Dawson, who couldn't be here today, unfortunately. But then almost immediately afterwards, we got an email from Hillary telling us that we had to re-record the entire thing because all the data had changed. It's not often that we record on topics where things change this quickly. And certainly that needs to be said multiple times so that people truly understand how dynamic of a situation this is and how everything that we hear today could be different tomorrow. And that's just because everyone is learning at such a rapid pace right now and things are changing so quickly. So Hillary, thank you for taking the time with us to be with us today.
Absolutely.
And
thank you for having me.
We're going to ask you some of the questions that Poonam referred to, and then just some other questions that some of our listeners have been sending us. These are, I think, softballs for the most part, but I think the reality of the situation has made them a little bit faster pitch, if you know what I mean. Right. There's also a FAQ that we're going to post on wildhealth.com. So if any of our listeners would like to get sort of access to some of this information without having to listen to the entire podcast again, we'll post a FAQ up there to wildhealth.com. So let's get started. There's currently 100 million pregnant women worldwide, obviously quite a few of those in the United States. And a lot of them want to know, are they at higher risk of severe disease from COVID-19 than everyone else?
Yeah, I think that we can kind of think about this in, COVID infection and pregnancy in two different ways. One is the risk to the mom and one is risk to the baby. And as far as the maternal risk of complications is concerned, the story starts when the WHO visited China in mid-February, and which I think is brave of them to go themselves. And they investigated 147 pregnant women, 64 confirmed COVID positive and 82 suspected. And what they saw was 8% had severe pneumonia and 1% were in critical care and required critical intervention, and there were no maternal deaths. And so they did not look at neonatal outcomes and they didn't look at vertical transmission. And so from that kind of assessment, they made the statement that pregnant women are not at higher risk than the average population from from COVID with respect to severe pneumonia or need for critical care. Then the next data that we had really was a 9-case series that was published in the Lancet that essentially they had 3 cases of COVID in the 3rd trimester. None of the moms developed severe pneumonia. 4 of them went into preterm labor, and all of them were underwent cesarean section. And that was a really quite reassuring, albeit with 9 cases, that it looked like, at least compared to the other coronaviruses that we know about, that COVID-19 was less risk than the other coronaviruses. So if you look at SARS, the overall mortality rate in SARS was 10.5% for moms. And sorry, that's wrong. We have a 12-case series of SARS of pregnant patients, and there were 3 maternal deaths, which that's a 25% mortality rate. And there was a lot of IUGR. Same with MERS. The perinatal death rate was 33%. And so, out there right now, kind of the next step in the literature was a case review of 41 cases included in an overall coronavirus meta-analysis. And then we started to see a little bit more data it documented that there was less need for admission to the ICU, and the death rate associated with COVID-19 was much lower than those other 2 coronaviruses. And that was kind of where we ended after we recorded the last podcast. Since that recording, there's been a couple of other publications, and these are just really, obviously those journals aren't published. It's EPUB's ahead of print, right. And they're starting to report. There's a cohort study of 16 COVID patients compared with 45 other patients who delivered at the same time who were negative for COVID, which I think is starting to get a more accurate picture, because these are people existing in the same circumstances, which I think is a really important comparison, considering what's going on right now. And there were no differences with respect to preeclampsia or fetal distress. And based on the other data, I think that the numbers were simply too small to see the fetal distress. Sure. And nearly all of the case series that we see, about somewhere around 40% of 30 to 40% of the moms infected with COVID have developed fetal distress. And I think that speaks to the idea that fetal well-being is another vital sign that indicates maternal well-being. So the women who are developing severe pneumonia or respiratory failure, the fetus develops distress, and then that becomes an indication for cesarean section. And so, to complete that description of the cohort study, 3 of the infants born to those COVID moms were diagnosed with a bacterial pneumonia. But all throughout all of these case studies, the testing of umbilical cord blood, amniotic fluid, and the nasopharynx of the neonates has all been negative for COVID-19. And so that was reassuring overall. And I think that, when I step back a little bit from looking at the details of the data, it seems like there's certainly risk of respiratory failure and respiratory need for critical care in maternal infection and COVID-19. I think the true incidence of that is really difficult to determine from a very small case series. Yeah. And when I really became alarmed at kind of the discussion, so until the end of this past week, all of the governing bodies and that initial WHO statement that there really is no increased risk to moms, that was kind of what everyone was really buying into. And there was a case series of two published out of Columbia, New York, that came out on Thursday. And it described 2-term patients presenting to the hospital without any symptoms, and they both underwent induction for various reasons. They admittedly, they had some pre-existing comorbidities. One had type 2 diabetes and the other one had chronic hypertension. And in the midst of their deliveries, each of them developed severe respiratory distress and tested positive for COVID, were intubated. One, and I think this speaks to, the nature of pregnancy. She was intubated, but she still went home post-op day 4. And she did great. The other one at the time of the publication was still in the ICU.
Okay.
And so, that is, the situation is unpredictable as usual in pregnancy is my synthesis of all of that.
So the data is, it sounds like, still fairly minimal in terms of numbers, but it also sounds like for the most part, just the numbers that I heard you going through, women aren't at especially at least a very large increased risk just by being pregnant. So their age, it seems, is protective to some degree, just like it would be for a non-pregnant person who's in their 20s or 30s, right? Is that a fairly accurate assessment?
Yeah, I think that, we know that they have age, and these are a lot of these case series, they're in their 30s to 40s. So age is protective. And in most of the case series, they did not have any pre-existing medical conditions.
Right.
And I think that we come to that in the general population, that pre-existing medical conditions mean a lot with risk of severe respiratory failure. And then the other piece of it has to do with gender, and we're starting to sort that out.
Right.
It overall is protective as well.
Right. And one thing you mentioned as well is it seemed like a lot of those patients had cesarean sections rather than vaginal deliveries.
Yeah, and so when I first began looking at this data, my assumption was that this was, essentially obstetric care. Mm-hmm. Specific to China. Okay. And then which admittedly was probably naive at this stage. Now, when I start looking at the amount of fetal distress and the rapidity and the speed at which maternal pulmonary failure occurs, mm-hmm. and admittedly, I haven't cared for any of these patients, but the description in the literature of how quickly it happens, I am starting to think that cesarean section is kind of the least of all evils in this situation.
Gotcha.
And obviously that's probably a very controversial statement, but if you think about if you're inducing someone and they're going to be in labor for 2 or 3 days and they're COVID positive, and you start to think about the risk of the care providers around them and all the PPE and all the fluid management that they get in the setting of an induction, perhaps a C-section is not a bad idea.
Yeah, because I definitely heard that it's best to keep these patients fairly dry, not get them volume overloaded, and from a respiratory standpoint. So that's something to keep in mind as well. If they are COVID positive, we don't want to be flooding them with fluids, and you can certainly do that a little easier, it seems, with a cesarean section than with an induction. That does bring up the question that another question that we're hearing quite a bit from our listeners is baby going to be safe? Is the baby going to be okay?
Yeah, and so in the case series until Thursday, essentially all the data pointed to there was no maternal fetal transmission. And then what happened is there were 2 publications that came in, they were published by JAMA Pediatrics. And one of them is a description of 33 cases of infants born to moms in Wuhan and into Wuhan's Children's Hospital. And 3 neonates with COVID were identified. And so until now, there were two neonates in the literature who were thought to be infected from exposures postnatally.
Okay.
And in these neonate situations, it was exceedingly controlled postnatally. They were isolated from their moms. The moms wore N95 masks during delivery. And so they describe 3 infected neonates, 2 of which were term, and the moms presented with pneumonia, and they underwent cesarean section, and nasopharyngeal and anal swabs were positive for COVID on days 2 and 4 of life, but both negative on day 6. And so because they were so well isolated, they think that this was neonated COVID-19 conferred from the mom.
Okay.
It's interesting to know that all the maternal fluids around them tested negative, like it has in previous. And then the last infant was preterm, 31 weeks, and that infant and these infants also showed evidence of pneumonia, but the term ones essentially recovered from their pneumonias. The 31-weeker, which was the 3rd case, had a fair number of complications, but it's also hard to know if that was related to its prematurity. And so the other interesting study was, well, actually, it's essentially one case where they tested the IgM and the IgG of the baby. And the time course of this case is really interesting. So the mom presented with COVID-19 symptoms on January 28th, and she was 34 weeks. And then 4 weeks later, she developed the pneumonia, it sounds like, and then she was admitted 3 days later, and then she didn't deliver until, and so she was given all the antiviral, antibiotic, steroids, oxygen, and then she delivered 23 days later. And so this infant was there, in the midst of her mother's COVID-19 infection, even pneumonia. And 3 weeks later, the mom wore an N95 mask, didn't hold the infant, and her IgG and IgM were positive, the babies.
Oh, so potentially getting IgM and IgG from mom?
Well, IgM doesn't cross the placenta.
Well, there's a problem. How'd that happen?
There's a problem. There's a problem. And so it's interesting.
So potentially the virus crossed the placenta, baby developed an immune response to the virus. I mean,
correct.
Wow. Okay.
And so, there's just really a lot of questions, because many of the babies that were in the original case series of the moms, their nasopharyngeal PCRs were negative. And so, and I guess they're not breathing in utero, so one would not assume that's the avenue by which they would get their infection. But the cord blood has always been negative as well. And so we're really trying to sort this out. In the case series, there are infants that act, like they have severe pneumonia, and they, a couple have had some multi-organ failure. And that is worrisome, but we've just never been able to detect it. And so these two, that case series and that, it's actually a letter, I believe, into the JAMA Pediatrics, is kind of changing what we think about that.
Interesting. And I imagine there's something to do with timing too as well. I mean, if you get it earlier in pregnancy, that it seems like the fetus is less likely to develop an immune response. And then if you get it later in pregnancy, maybe their immune system is a little more developed and they're more likely to develop it. I mean, I'm guessing.
Yeah. I mean, I don't know. I guess what I would say is, what has struck me as I've been reviewing these all this literature, is that there's a lot of misuse of terminology, in my opinion. And, in some of the studies, especially the one that reviews all 3 coronaviruses. Sometimes they say that there's risk of miscarriage, but that was the only data that we have on miscarriages for SARS. There's no data on COVID, as you would know, because it started in December. And there's also some statements about preeclampsia that COVID-19 might increase your risk of preeclampsia. And that's hard to tell. I mean, there's been patients who have preeclampsia in these case series, but, I don't think we have enough data to say that. And in most of them, there's not an increased risk of preeclampsia. So that has been something that's been floating out there that when I looked at the data, it did not seem clear to me at all.
Yeah. And I think it's tough to take COVID-19 and compare it to SARS and MERS, at least for this specific example, just because the case fatality rate for both of those were so much higher than we're seeing for COVID-19. I mean, pretty consistently, at least in the States, we're seeing, less than 2%, whereas SARS and MERS were, 10 to, I think, 30% off the top of my head. I can't remember exactly, but they were much higher case fatality. So I think because of that, we would expect more, maternal and fetal issues. At least that's what makes sense to me. So how can women expect to see a change in their prenatal care if they have COVID? I would expect they're probably not going to get the same sort of treatment that the normal population would.
Yeah. And so pretty standard prenatal care for low risk patients is around 11 to 12 visits. And that often doesn't include their ultrasounds. And there are a couple of published protocols, one out of University of Michigan, the other out of Mass General, and they're down to like 5 or 6 visits in this setting, mainly to avoid exposure of the patients to the healthcare setting, but also when your community has COVID in it, it's also to protect the healthcare providers. And what I think is really important for people to understand is that we have studied prenatal care with decreased frequency of visits and have proven it to be safe in low risk situations. Mm-hmm. And this is outside the setting of a pandemic. We tried it mainly to improve patient satisfaction and we have not seen like things get missed. And so I think that, if people are feeling anxious about this, what's most important is that if you have an issue that can be taken care of with telehealth, I think that's also what's going to be sprinkled in there is that most of our concerns can be addressed either with telehealth or with the routine visits. But, getting a visit for worrying about contractions if you're preterm and that type of thing is still important. And so, that's what's going to be offered. It's safe, but, we certainly don't want to have people out there with languishing problems and not getting care.
Right. Yeah, that makes total sense. I expect that there's going to be some changes in sort of how the delivery goes down too. I mean, it sounds like there was maybe even an increase, cesarean rate in some of these case series. So there's probably going to be some changes in the delivery room, right?
Yeah. And I think kind of leading up to the delivery, and this is something that was just brought out this week as well, is they're proposing that you isolate starting at 37 weeks because what is really important is that in the setting of your delivery, as you get closer to term, contracting COVID could potentially really complicate your delivery, but also expose a lot of individuals in the context of your intrapartum course. And so that's one of the things, pretty exclusive social isolation starting at 37 weeks. And if you want someone to come with you to the hospital, if your local and hospital environment is allowing that, having them isolate quite exclusively as well would be important. And the delivery, and this really depends on where you are. There's a lot of variation as to where geographically where people are at in this pandemic. And my understanding is that in many hospitals in New York, women are not being allowed a support person. And that has caused a lot of concern on behalf of a lot of people. And you might imagine it's exacerbated because people are going into your room less often, to decrease use of PPE, to avoid exposing the patient. And then if you don't have a support person, that makes it more difficult. And so those are two of the things. The other thing to understand is that if you have a scheduled induction, depending on what the reason is for the induction, the timing of that could be changed. So for example, if you are 39 weeks and your area has not seen the surge of COVID patients that they're expecting, your provider might offer you induction
Get that thing
sooner. Right. Get delivered, get home, and get back on isolation potentially.
Certainly.
Whereas if you're planned, if your hospital is in the midst of their surge and you have an elective, a by choice induction scheduled at 39 weeks, and you're going to spend 2 days in the hospital getting induced, they might not offer that to you because if you wait till spontaneous labor, you'll be in labor for maybe 5 or 6 hours, and then you'll get to go home that day or the next.
Right.
And so all of those are considerations. Obviously, if you have a medical reason to be induced, that's going to be really difficult to delay. And so it all kind of just depends on what your situation is. The other thing I think is important to consider is if you have been seeing one provider and you're kind of planning on them being at your delivery, if they get exposed, if they're sick, they might not be there. And a lot of systems are repurposing their providers. And so potentially they're offering, when it's clinically appropriate, midwives to patients who have been cared for by doctors. And, I think in this situation, flexibility is good, but it's just a slightly different expectation than perhaps 6 months ago.
Yeah, certainly. It seems like that while you might expect to have a different provider on the day of the delivery, you still would have to communicate with your provider a lot about how to do this right. It's should I bring my partner? Should we expect to see the baby immediately afterwards? Like, just communication needs to be open between the obstetrician and the patient to make sure this thing really goes down in the right way. Timing and everything else.
Right. And there's a couple of other things that I think might be good. And that is if nitrous oxide was your plan for pain control and that's offered at your hospital, because that is being considered a potentially aerosolizing procedure, most hospitals are not offering nitrous oxide for now. The other thing that's discussed in the literature, and I don't know how much people are going to be doing it, I think it depends on your risk factors, but being very aggressive with medications to prevent bleeding and hemorrhage is recommended because we're having a blood shortage right now, and preventing blood loss is really important at this stage because we just don't have enough of it. One of the things that also can, and this is really geographic, it varies geographically, is that some people start their inductions at home. For example, they'll use a Foley balloon for cervical dilation, and some providers are really used to sending patients home in that situation. And but many locations like here, we haven't historically done that, but we're trying to look at ways that we can really keep patients out of the hospital. So those are kind of the main changes in expectation of intrapartum stuff.
Okay. And what about after delivery? So I would expect if mom has COVID, then there's got to be something to consider in terms of her interaction with baby, right?
Yeah. And this is, I would say that based on what I can see in a lot of the literature, so the CDC strongly recommends immediate separation of mom and baby, and that and the duration of that is kind of determined by care providers and kind of the clinical course of the mom. And that breastfeeding, she can pump and feed breast milk with really careful hygiene. And the WHO doesn't actually totally recommend that. They say that she can breastfeed with an N95. But I think that kind of the clinical practice is that they're separating moms and babies, which I think is, outside of the setting of a pandemic, we would all be devastated about. But knowing that we don't know what the risks are to our babies, we might hang in there for this recommendation. But I'll say that as availability and space in hospitals is starting to change. They are cohorting babies. So you can see that in the case studies out of China, that when they had a COVID positive baby, they put other COVID positive babies in with that baby. And so that, because they just didn't have the space to keep everyone separate. But I think that is probably the biggest part of the postpartum care that has changed. And as far as being someone who isn't COVID positive, but being evaluated for that, I think that depending on the level of clinical suspicion, that's going to happen. And the other thing that even if you're totally healthy and you are not COVID positive, you should expect that you're going to get discharged from the hospital much sooner than you may have been 6 months ago. And so they're recommending, maybe 1 day postpartum stays for vaginal births and two days postpartum for C-sections, which, was a whole day sooner than for both of those procedures previously. Or they're also recommending postpartum visits for telehealth. And I think that's really valuable. It's really hard to get out of your house anyways when you're postpartum. And then the other relevant discussion is, there's so much talk about how ibuprofen might worsen the clinical course of COVID. And ibuprofen is such a mainstay of postpartum pain treatment that, currently our governing bodies are saying ibuprofen is still what we should use for postpartum pain. And I think, that probably depends. If you become symptomatic, you should probably reevaluate that. But currently we're saying you can still use ibuprofen. And so though, I guess this is where I'd kind of like to put out there that I think, and this is perhaps my public health hat, one of my biggest concerns about women and families in the setting of this pandemic is being postpartum in the setting of social isolation sounds nearly untenable for many of us.
Yeah. I mean, that's, yeah. I was about to say something very, very similar to that. I mean, this is like, what a terrible time to be isolated, and not just that. I mean, even if you just think of, I've had two children. You've had three. That those postpartum nurses are like a godsend, right? And if you are COVID positive, I can't imagine they're going to be in there constantly, like they typically are, helping with nursing, helping with the baby. I mean, this is like, what a terrible time to be socially isolated, right?
Right. And I think that, in our community, we're currently trying to relocate all of our lactation services to outpatient clinics who don't see sick patients or who are closed and aren't seeing any patients because, the postpartum time period is really difficult when you have all of your resources for breastfeeding, for postpartum depression, for adjustment. Yep. And I just am really worried about all our moms recovering from, and if they've had a difficult delivery, and they start out kind of being afraid of this whole thing. Right. So, all that we can do to support people without actually being in contact with them. I don't know. We'll have to see what that looks like as we go.
Lots of meals on wheels and everything we can do. I mean, yeah. And then, the other thing that we haven't mentioned, but, just all the support you typically get from grandma or granddad, right? And now those are the people at the highest risk. So certainly you can't be exposing them. It's a tough time.
Yeah, absolutely. I am hoping that we find good ways to do this, and Skype, Skype and FaceTime and all these ways of connecting, they might not hold your baby so you can shower is the only problem.
You could take a shower with the baby, I guess. I don't know. So are there any other things that are different about obstetric care for COVID patients that we should cover?
Yeah, I mean, I think, and this to the clinicians out there who are kind of might be in the position of encountering a pregnant patient with COVID, there's some new things to think about. And one of them is that our usual intervention when we are caring for a patient who is at risk for delivering, who is less than 34 weeks gestation, and we think they might deliver in the next week, we typically give the mom systemic steroids, betamethasone. And currently, right now, we think that makes COVID infection worse. We think that, I mean, the data isn't great, but we're worried about that.
Right.
And so there's a published, essentially a rubric of you take into consideration the level of disease that mom has and what her risk of delivery is and what her gestational age is. So for example, while we would always give someone 32 weeks or 33 weeks gestation steroids if we think they're going to deliver, if they're pretty sick with their COVID, we might not do that. And so that conversation is probably a perinatology intensivist conversation, but it's just some of our knee-jerk interventions are being questioned at the moment.
I haven't even thought of that. I mean, it's interesting that some of the data on methylpred out of China actually suggested some benefit if given later in the course. So maybe the sicker moms may potentially tolerate it, although they might have a higher risk of pneumonia after COVID clears. But the early data looks like, or giving it early in the course looks like it's potentially bad and could cause progression of the disease. Man, what a conundrum. Because I mean, this is standard of care for the young babies, right? I mean, the preterm infants.
Definitely. I mean, multiple randomized studies have shown that it decreases the infant's risk of respiratory distress syndrome and decreases mortality and intraventricular hemorrhage and necrotizing enterocolitis and also systemic infection for babies. So these are the main outcomes that we're doing it for. And so it's also something to think about when you look at the fetal outcomes. They probably aren't going to be as good as in moms who got steroids if we're withholding them. And so it's all a very complicated picture. The other intervention that we historically, many people have done is Inductions for preterm birth or preterm labor. And that, of course, is an anti-inflammatory. And, there's a paper right now put out there as a recommendation for COVID positive pregnant people. And the recommendation is to use nifedipine as an alternative. And then the other thing we have to kind of think about is if we have a preeclamptic, magnesium can certainly affect pulmonary function. Certainly mag toxicity does. And so if you have a sick preeclamptic, hopefully they don't have COVID too. But if you have a sick preeclamptic, you want to be really careful that they don't get mag toxic and further compromise their pulmonary function. And we also use magnesium for neuroprotection in preterm birth. And, there's a whole rubric, and that's an entire discussion with a perinatologist and the neonatologist and the intensivist about what moms might be able to tolerate mag sulfate. The other thing that is interesting, and I think that in some of the studies, is that COVID causes thrombocytopenia and a transaminitis, both of which are diagnostic criteria for preeclampsia. And so it clouds the picture of which do they have. Right. And so it's just something to have in mind. If you have a preeclamptic who, might have, that transaminitis, you might be attributing it to preeclampsia, but it could be the COVID instead. And then, the other things that I can think of is, we typically consider maternal oxygen saturation as being best at greater than 95%. Most of these severe pneumonia patients are, treated like ARDS patients, essentially the permissive hypercapnia and the PCO2 around a PCO2 of 60. And so there isn't current evidence that that's bad for babies, but it's just kind of this sticky situation about how you manage those patients. And in their third trimester, some patients might require increased PEEP just because of their intra-abdominal pressure. Of course, always the left lateral tilt positioning and the usual blood pressure management of pregnant patients of less than 160/110. So those are obviously very basic things, but I think that clinicians might find themselves taking care of sick pregnant patients. And sometimes those things that we learned long ago, we have to come back to them if we're taking care of patients in this setting.
Some of this sounds extremely complicated in terms of deciding what therapeutics to give, and at least in complicated pregnancy, whether it's complicated by COVID always complicated by COVID, but when it's complicated by things like preeclampsia or preterm labor, has there been any discussion about these patients getting transferred to locations with like maternal fetal medicine docs, or is this something that we should expect to see staying in the community?
No, I mean, I hope that these are all cared for by intensivists and perinatologists. But I think that our usual resources that we would have available to us for potentially for transfer, or for example, in my community, there are 2 perinatologists, and if one gets sick, and so I think that hopefully sick pregnant patients are going to be cared for by clinicians of that, training. But I think that, maybe potentially they walk into your ER and you have them for a little bit until they get someplace else. Yeah. Or maybe there are some family docs or general OBGYNs like myself who are listening who, haven't looked at the literature in the last 24 hours. I mean, that's hard to make that commitment. We're all so busy right now with trying to take care of patients and figure out how to deal with this. So I just brought it up to know that there's really great resources that just came out this week, and they're available to all of us.
Awesome. Well, thank you, Hillary, so much for your time. I appreciate you going through these questions with us. Did you have anything else that you wanted to share? Or?
No, I think that, I guess my concern, and I think one of my biggest concerns has been for our pregnant healthcare providers, because certainly initially, and really probably until this week, our message to them was, everything is fine and wear your PPE, and I'm pretty worried about them. And I, especially in the setting of no PPE, and I would say that the providers who took care of those 2 asymptomatic patients in New York who then turned out to have COVID, those deliveries exposed more than 15 healthcare personnel per delivery, because people weren't offered or recommended to use the appropriate PPE because the patients were asymptomatic. And, that takes a lot of our workforce away from the rest of everyone having babies. And just like we just need to curate our providers in a way that we're going to be available to everyone who needs us. And so, it's people are really in a tough spot to decide between taking care of their patients and protecting themselves and their pregnancy. So,
and we've certainly got to take care of our providers, pregnant or not pregnant, but certainly it sounds like the pregnant ones, because it doesn't sound like this is maybe as benign as we initially thought in pregnancy. So I think it's important that we protect everyone as best we can, and certainly our pregnant providers as well. All right.
Yeah. Thanks, Mike.
Thanks, Hillary. Have a good day.
You too. Bye-bye.
If you have pregnancy-related questions and want to ask them of our OBGYNs, send us your questions at Wild Health MD, or you can ask them yourself. We're having a summit on April 4th through 6th with Ben Greenfield, Dr. David Sinclair, Dr. Matt Cook, many other brilliant minds in medicine and health, as well as our OBGYNs who you heard on today's podcast. It's 100% free, but you have to register at wildhealth.com. It's limited registration as we're letting the audience interview the guests, and we have limited numbers that we're allowed to let in through our streaming software license. But if you want to ask your questions or listen in, join us by registering at wildhealth.com.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.